Welcome. First of all, I'd like to thank you for taking the time to be here and allow me to present my research. Second, I would like to thank the Flemish Research Fund, Krelan and VZ2 Dodentocht KD for their financial support of our work. As a response to a rapid rise of COVID-19 infections, the Belgian government were forced to impose drastic social restrictions both in March 2020 and in October 2020. As of January 2021, a nationwide vaccination program is ongoing to counter SARS spread. By now, the vaccination campaign has created sufficient margin to gradually ease the social restrictions by the summer of 2021. All in all, non-pharmaceutical interventions such as stay-at-home orders, social distancing, testing and tracing can now be replaced with a pharmaceutical intervention, vaccines. Inarguably, the use of vaccines is preferred over the use of social restrictions, but the containment of SARS has depended solely on non-pharmaceutical interventions for nearly 1.5 years. In case of a future SARS outbreak, or even more general, a future pandemic, epidemiological models can help policymakers choose the best non-pharmaceutical interventions to prevent the collapse of the public healthcare system, which is called the hammer, and to choose the best cost-benefit social distancing measures to keep cases as low as possible and perform the dance. The dance ends when enough people have been vaccinated so that a full release of the measures cannot overload the public healthcare system. For Belgium, this point, called the tipping point in the figure on the slide, is expected to fall around the beginning of June 2021. The first step towards understanding, forecasting and assessing the impact of SARS on society is the development of an epidemiological model that incorporates as much a priori knowledge on the characteristics of SARS as possible. The model developed at Ghent University accounts for pre-symptomatic infectiousness because it was estimated that roughly 44% of all transmissions actually occur before the onset of the symptoms. Infectiousness before the onset of symptoms has a very large negative impact on the efficiency that can be obtained using testing and tracing strategies. The model further accounts for different disease severities. It's estimated that roughly 50% of all COVID-19 infections are actually asymptomatic, which means these patients have no symptoms. Patients' mild symptoms can evolve into severe and critical symptoms that may require hospitalization. Since the disease severity depends largely on the age of the individual, our model simulates the disease using 9-10-year age strata. In this way, the odds of severe disease are much lower for a younger individual than for an older individual. In a second step, the model is matched to the Belgian hospitalization data by estimating model parameters in order to mimic the real-world pandemic, a procedure which we call model calibration. The a priori knowledge that we incorporated into the model structure can then be combined with new knowledge gained through model calibration to gain even further insights in how SARS spreads across generations and in different places. A first example of such an insight is demonstrated on the slide. In blue, the basic reproduction number as estimated by our model is shown per age group. The basic reproduction number of the virus is a measure for how fast the virus spreads before measures were taken. It can clearly be seen that youths and the working population have a much higher basic reproduction number than the senior population. And this is mainly because the former have much more social contact than the senior population. In striped orange, you can see the expected fraction of the total Belgian hospitalizations during the first COVID-19 wave, as predicted by the model. It is clear that the youths and the working age population are the pandemic's motor with high basic reproduction numbers, while it is mostly the senior population that is in need of hospital care. Through a combination of being sociable, mobile, and having a very high hospitalization propensity, we find that the biggest at-risk population are the 50 to 70-year-olds. So we expect these individuals to turn up to the hospital the most. A second example is the role of schools during the pandemic. At the start of the pandemic, it was believed that children were less susceptible to SARS infections. However, children hardly develop COVID-19 symptoms. Since worldwide test capacity was very low at the start of the pandemic, this claim was most likely false. It was most likely due to underreporting of cases in children. By splitting the effective reproduction number in our model between leisure activities, workplaces, home and schools, shown in the figure on the slide, we found that schools are a major contributor to SARS spread. Even under lockdown measures, schools can increase the effective reproduction number above the critical threshold value of 1, which is the point at which SARS starts spreading exponentially again. Schools reopening have caused stagnations of the hospitalization curve both before and after the Christmas holidays. If schools would have remained closed between autumn break and the Christmas break, the curve would have likely been crushed by January 2021. Based on these insights, we advised the Federal Minister of Public Health to close schools 1 week early before Easter holidays and found this to successfully counter the third COVID-19 hospitalization wave. Using our calibrated epidemiological model, different scenarios can be explored to advise policymakers, to attain a stronger position with present government bodies, and to communicate a strong and coherent message. 15 researchers of the universities of Ghent, Hasselt, Antwerp, Namur and Brussels united forces in a modeling consortium named RESTORE. At each of the aforementioned universities, an epidemiological model was developed. Through regular meetings, tangible scenarios are made up, simulated and the results discussed. The model results are placed together on one figure, the so-called ensemble. On the slide, the most probable future scenario is shown. Every model accounts for the new variants of concern, which is mainly the British variant, which is more contagious, and the ongoing vaccination campaign. Socially, drastic relaxations in June are simulated. The top panel shows the daily hospitalizations in Belgium, while the bottom panel shows the total number of patients in the hospitals. Even under the speedy vaccination campaign, where currently 55,000 doses are administered per day, a minor fourth hospitalization wave is still possible, and pressure on the healthcare system will remain high during the process of relaxing measures. However, the good news is that even under full relaxation of social restrictions, the pandemic will fade out. In other words, the tipping point will be reached by June 2021. Even after pressure on the healthcare system has faded, it is expected that the virus will continue to spread in regions with lower vaccination rates or by importation of cases from other countries. At Ghent University, a spatially explicit variant of our model was developed. The model simulates the disease in every Belgian municipality and accounts for the mobility between the municipalities by using detailed cell phone data provided by Proximus. The model will be used to monitor and predict the spread of SARS at the municipality level. In this way, if infections in a certain region start rising exponentially again, extra vaccines can be administered in those regions, or, if needed, a local lockdown can be used to prevent the virus from spreading further, much like was done in Antwerp province during the summer of 2020. Based solely on the epidemiological models, we may conclude that in order to safeguard our hospitals, we should simply lock everyone in their homes. However, this comes at a great societal cost that is typically not considered in epidemiological models and which is certainly undesirable. As previously mentioned, schools were closed 1 week before Easter holidays to counter the third COVID-19 wave, because closing schools was found to be an effective means to counter an epidemic SARS outbreak. In this case, the societal cost of closing schools was small, since pupils have few classes in the week before Easter holidays. Little quality of education was lost. But we should still ask ourselves the question, do we want to close schools to counter an epidemic SARS trend? The answer to that question depends on the net balance between the costs of closing schools and the costs associated with the additional loss of life quality if the schools aren't closed. in order to quantify tedious questions like these, a health economic model and a macroeconomic model were implemented at Ghent University. The health economic model can be used to compute the number of quality-adjusted life years, or QALYs for short, lost to COVID-19 due to mild disease, hospitalization, death and long COVID. The QALY model further accounts for the comorbidities of the COVID patients. Currently, we are trying to incorporate the effects of mental well-being, schools closure, and the effects of postponing non-COVID treatments in the health economic model as well. The macroeconomic model can be used to quantify the economic losses due to sector closure, changes in consumption patterns, and changes in imports and exports. Because the models are coupled for every proposed social policy, the effect on virus spread, as well as the associated societal and economic costs, can be computed. In this way, the holistic model can inform us about the strategy that is most beneficial for all aspects of society, rather than only safeguarding physical health. Based on these arguments, it is clear that, although convenient, an epidemiological model alone is insufficient to aid policymakers in governing the dance at the least overall societal cost. Epidemiological modelers should extend their scope beyond the virus and try to assess the effects of the virus in the complex system that we call society. Developing a truly holistic, multidisciplinary model that is able to quantify the foremost costs associated with a pandemic is ambitious, but should be developed nonetheless. If an estimate of the virus' societal costs can be made, then complex algorithms can be used to choose the non-pharmaceutical interventions that mitigate the overall societal costs and at the same time prevent the healthcare system from collapsing. Such multidisciplinary models are the future of epidemiological modeling.